Today is our second call furthering through spring program, and we have Dr. Ritu Patel, who we will talk with her about her experience as internal medicine doctor. But before that, I have a little bit of announcements. You guys have been reaching out to us through DMs on Instagram, and I've responded to those DMs. And I've noticed a pattern that a lot of you guys are confused about some of those things like summaries, how do I sign up, stuff like that. So I'm going to take a few minutes before we proceed with the shadowing session with Dr. Patel and make sure that's clarified, and then we'll proceed with the shadowing session. Okay. So we'll go everything to if I have to say one thing, everything that you need to know is in the bio of our Instagram. So common question that we get is, how do I sign up? You don't have to, we don't have a formal sign up. All you have to do is attend these YouTube live streams. And you can, if you need verification for your hours, we will do that for you by sending us a summary, okay? And you can, regarding having information about what goes into summaries, if you click on guidelines and putting sessions on application or resumes, we have it right here for you guys. We have it here. If you want to list it as a virtual shadowing experience, how to go about that. So after you attend this call today, if you want verification, you can send us a summary to the email that's on the screen that you see. And then typical question that I saw in the chats was also like, how long does a summary need to be? 3 to 5 sentences. We're not looking for you to write us an essay. The goal of the summary is for us to know that you attended the call and you took something out of it. That's all. We keep it simple. We don't want to complicate it too much for you guys. Any format is fine. Write it in. If you can write it by hand, you can type it. Anything is fine, as long as you show us that you've attended and you give us something that you learned that's good for us. In terms of sending them out, we recommend that you hold on until the end of the program, which will be in May. And then you can just keep compiling all your summaries week by week and then send them together. The reason we say that is because it's quickest that way. So that way we can read through all and send them to you guys. Usually the fastest way to do. But with that being said, you can also send it week by week as you desire. We understand sometimes it can be urgent. So we'll try to quickly process those. Usually takes about within 1 to 2 weeks we'll process, but sometimes we can get backed up and it can take us longer than that. If it's taking us like a month, DM us. There's a chance that either we didn't receive your summary or something along those lines. There could be a technical difficulty, but we'll take a look for you and we'll get that fixed and we'll get back to you. Okay. All right. So let's go back. One more thing regarding how to sign up. There's one thing that you can sign up for and it's called registering for virtual shadowing call reminders. So if you click on here, it'll lead you to a Google form. So you can put your name and your email. And what this does is that it gets you to gets your email to us, and we have a program where we send out weekly emails and reminders where who are we going to have for this week, what kind of specialty are they in, and we send that in advance. That way you're informed through your email. So you can sign up for that if that's something that interests you. Other than that, we also have volunteering opportunities. So if you click under register to volunteering, we actually have 2 separate accounts. So the volunteering is through, if I go back to the Instagram for our volunteering page is at officialclubmed.volunteering. So if you go under there and click the link in bio, these are all the things that you're going to see. And we have a lot of interesting programs that you can do to volunteering from home. We get that it's difficult to volunteer because of COVID. So if you're looking to do something from your home, this might be the place, and there's a lot of options for you to do. If you're looking to get some information, I would start by clicking on how to start volunteering. And right over here, we have explained the guidelines of what you need to do. So read through that first, and then also read through the programs that we have. And after that, you can reach out to us regarding what you want to do, and everything is here. Okay. And other than that, if you still have any other questions that you want to know, just DM us on Instagram and we'll get back to you. And then that's the quickest way, but you can also email us. I think that's all, but one more thing right here. Another question that I saw a lot is that, can I write summaries? We have had about 12, 13 calls. Can I write summaries from the previous call? The answer to that is no. The reason for that is that we want to keep it if we keep it open, it might be difficult for us to get back to you guys. So that way we keep it about 4 months. That's typically what the program is, and the spring program will go until May. So all summaries, the Ring Through program started last week. So if this is your first time, we had a call last week too. So starting from last week's call up until May, you can write a summary and we'll get that. If you send us a summary, we'll verify that for you. But all of the previous calls, as of now, we have those closed. But if anything changes, we'll update you guys through our Instagram. Okay. With that being said, that should be all. If you have any questions today, just you can use the chat feature on YouTube, and I will do my best to get those answered from the doctor. Okay. So there's announcements. Now let's get started with the shadowing event. So today we have Dr. Ritu Patel. She's an MD. She's an internal medicine nephrology physician, and she's board certified. So I'll let her stop sharing. And Dr. Patel, you can share your screen.
That's good. Let's see. All right, bear with me because this is the first time I'm using Zoom for an actual event, not just family chats. So we're going to talk a little bit about the kidneys, but before that, I'll give you a little bit of intro and insight into who I am and how I got here and things of that sort. So my name is Ritu Patel, specialize in internal medicine and nephrology. You can follow me on TikTok at the Bean Doc, and then of course follow Club Med, and their information is there at Club Med on TikTok and on Instagram. So no doctor is complete without their assistant. So I have my little puppers that comes to work with me. This is Dr. Snowball. She's the office assistant, takes naps whenever she can. So a little bit about me. How'd I get here? So I was born and raised in Houston, went to Texas A&M. I did my undergrad at 2 different locations. I did it at their main campus for 3 years. I majored in biology. And then I transferred my last year over to commerce because I was lured by the idea of Caribbean med school. So I went to A&M Commerce for about a year after wanting to make the decision, after making the decision to go into medicine. However, when I got there, I realized that the school that I was about to go to did not have many successful graduates. They didn't have a high match rate. They didn't have a high board passing rate. So I had to quickly change course and figure out what to do. So then I came across American University of Antigua. So this is one of the few noted major medical schools in the Caribbean. It had recently just started at that time around 2005, I believe. And they did have a pre-med program that was on the island. At that time when I went there, their semesters were every 4 months. So it was a rolling admission. So I applied, I got in for their fall/winter semester. So I did a 2 semesters of pre-med in Antigua, and then I matriculated into their medical program. But because this was one of the newer schools, they had a really high acceptance rate, but a very low number of rotations that they had already secured by the time I was ready to start rotations. So in April of 2010, I was going to have to wait about 4 months to start rotations, which would give me a big gap in my medical career, and it would be questioned. So I made a very dangerous decision to switch universities yet again and switch over to American University of Integrated Sciences, at that time known as University of St. Eustatius. Finished 2 years of rotations and then finally graduated in October of 2012. During all this time, I was starting to have interviews for residency. So a lot of questions were being asked. And there were a lot of red flags, which I'll talk about. Once I got into residency, I did internal medicine at McNeil Hospital in Chicago, came back to Houston to do fellowship at Houston Methodist, and then I started private practice in August of 2008, and that is currently where I'm at now. So in all of this, of course, board exams and USMLEs. So as you can see, not the best test taker. I did have to redo some of my steps. Step 2 CS, I had to take again, and step 3, I had to take again as well. However, eventually passed them all and was able to match despite this track record. So some things I was talking about, what was I worried about throughout this journey? Of course, my transfers, A&M College Station to A&M Commerce, then to the pre-med program, then from AUA to St. Eustatius. So all of those transfers, multiple transfers of schools. Of course, being a Caribbean graduate is a big red target on your back to get discarded out of potential interviews. And then, of course, multiple attempts to take the USMLE. All of those things did give me a little bit of, it did allow the program director to see that I was resilient and dedicated to my career of being a physician. I didn't let any of the roadblocks stop me. But why did I choose the Caribbean is a big question that I was asked by program directors. And, I was honest. I accepted the fact that the medical schools in the United States wouldn't give my application much attention. I didn't have the best GPA. I didn't have the greatest MCAT score. I didn't have a very competitive application for the United States medical schools. I set my dream to become a doctor. I was determined to become a doctor. I wasn't going to let anything stop me. I knew I could get in. A lot of these schools are for profit. So if you don't have the criteria to make it to a US med school, you can go there. However, if you don't have the determination to make it out, you will not match. And I was willing to put in the work. I definitely sacrificed a lot. I did a lot to get to where I'm at now. So kind of piggybacking on that, pros and cons of the Caribbean med schools. Of course, like I said, they're easier to get into. The US med school average GPA is 3.6 and an MCAT score of 31. Those things kind of go out the window depending on the Caribbean med school. Some of the more established ones, St. George, Ross, even now AUA, they are a little bit more competitive, but you can still get in with letters of recommendations and things of that sort. They do have clinical rotations in the US and rolling admissions. Although I think now they have, they've done to the 2 semesters a year. Again, the downsides, there's no guarantee. It's not like a US med school that has a 94% or 96% match rate. Caribbean med school, you'll be lucky if they have a 70%. Limited options for residencies. Again, if you're a more competitive student and you have better scores, you do have the doors open to you. However, it is a little tougher to get residency. And there's a lot of competition. Each semester they take about 300 students, maybe 75 of them at the end of the day will become a physician. So again, you have to really want this. What fears did I have? Not guaranteed a medical license. Some states don't accept Caribbean grads, although now some of the top tier Caribbean programs are licensed in all 50 United States. Like I mentioned before, they're a for-profit school. They're not there to hold your hand and walk you through medical school. You're away from your family, and the struggle to get into residency. You're climbing an uphill battle before you even have a chance to show them your grades, your abilities, your benefit that you would bring to the program. So the main takeaway I have with anyone thinking about going to a Caribbean school, research them thoroughly. A lot of them have groups that they have created for people to ask questions. Call their admission staff, get a list of graduates. That's what I did when I transferred over to St. Eustatius. I asked to get a list of where their students have matched into residency, and I reached out to them on Facebook or LinkedIn and asked them what their thoughts and opinions were, because at that point I'd gone through so many schools that I had taught myself that this is how I know I'm making the right decision. And don't be afraid to ask them tough questions. Ask them their match rate. Ask them, what schools that they're affiliated with the United States. See where their students are matching as far as residency goes. And they even follow them post residency. So see where they're getting licensed, see what issues that they're having, because these are big things that I wish I had known 13, 14 years ago when I was applying to medical school of, is this the right path that I'm taking? And I feel like if I had a little bit of the ability to figure these things out, I would have maybe not made so many transfers. But again, it got me to where I'm at right now. So, questions?
Yeah, Dr. Patel, I was going to ask you questions from the chat. So after everything, through the transfers, through all the difficulty, the job is done. So that's all that matters. But the questions were regarding to a couple questions through undergrad. So those who are in pre-med, what would you recommend, like kind of things that you should get involved in if they're in the US?
First of all, pre-med is not a prerequisite. So if you are struggling with pre-med and you are not liking some of the courses you're taking, you don't have to be a pre-med major. That is one thing that I wish I had known when I applied to medical school, that I didn't need to be a biology or pre-med major. Major in what you want. That will give you added benefit later in life. If political science is your thing, if liberal arts is your thing, do that, pursue that, learn about that, but take your pre-med courses, definitely show that you have interest in medicine in other ways. So take part in any sort of medical organizations your campuses have, be a part of health drives, continue to shadow doctors, continue to take part in research, expand your portfolio and don't just have it focused on medicine, because it'll help you throughout your life, throughout your career, in a lot of aspects of what you do.
Right. And then outside of that, outside of extracurriculars, having a strong GPA and MCAT will go a long way too.
Right.
Another thing that somebody asked was that after you finish your undergrad, did you take a gap year between going into Caribbean school or?
No, everything was almost consecutive. So if I go back and, I had to actually go through old transcripts and figure out this timeline, but it was summers in between each transfer. It was the summer of 2006 that I went from College Station to Commerce, the summer of 2007 that I went from Commerce to Antigua, and then it was very continuous. I tried not to have big laps in my transcripts because, again, these are things that schools will ask about, is what did you do in your time off? And you have to be able to show something for it. You can't just sit around and twiddle your thumbs.
Right. Okay. There was a question you said that I know what you meant by being able to take any measures as long as you um, complete your prerequisites. Somebody asked that, don't you risk not being able to take certain prerequisite courses if you major in anything?
I think it depends on the school. I know at A&M you were able to, and again, this was 15 years ago, but if there were prerequisite classes that you needed, you can get into them, and then anything else towards your major was required. But if you needed a prereq, and a lot of the prereqs for med school, again, I don't recall what all the prereqs are, but from what I know, it was really level 1, level 2 classes. There was really nothing, junior or senior year that you needed for med school.
I'm an undergrad right now, so based upon what I know from my experience, it's about 60 to 70 credits that you need for your biology, your chemistry, organic chemistry, your biochem, sociology, and psychology, and those are the classes that you need to take for the MCAT also to prepare you for that. But with that being said, you can still take those classes and major in anything as long as you've fulfilled those requirements. But it might be difficult, is the often question, but it can be done. Yeah. Completely agree. All right, okay, we can keep going.
Okay, so now we're going to get into a little bit of my bread and butter, which is acute kidney injury. This is something that maybe if there's more pre-meds in here, a little over your head, but if there's some med students and things like that, this will kind of fit stuff that you need to know for medicine. So I'm going to start off easy, some questions and answers, and then we'll go a little bit more in depth with the discussion about acute kidney injury. So you got the 74-year-old guy, diabetes, hypertension, chronic kidney disease. He sits around a creatinine of 1.7 and undergoes a coronary angiography. 2 days later, his serum creatinine is roughly the same, 1.8. Sent home. About a week later, though, he comes back with abdominal and lower extremity muscle pains. At this time, his serum creatinine's gone up to about 3.6. His amylase is elevated and a creatinine kinase of 470. His urine specific gravity is 1.012, and he has some blood, some protein on his urine dipstick, and he has about 3 to 5 blood cells per high power field with some white blood cells and some granular casts. So this is the main question that, nephrologists get asked is, why is this person's kidney numbers going up? So you got a couple of options there. You got contrast nephropathy, atherosclerotic disease, myoglomerulonic acute kidney injury, prerenal azotemia, and vasculitis. So looking at this, the answer choice is B. So the gentleman has atherosclerotic disease. And the reason why is, he got a coronary angiogram. We would think, some people would assume that it was contrast-induced kidney injury, but you usually see that within the first 2 days of getting contrast. But his presented about a week later. So that took out your contrast-induced AKI. He also has muscle involvement, and he has abdominal involvement with amylase going up and having abdominal pain. So B fits this profile more than the other ones. So the next question, you got a younger gentleman, was on a construction site and has his legs pinned under a pile of rubble. It takes about 5 hours to get him out. When he gets to the ER, he's found to have a creatinine phosphokinase of 2,300 and a serum creatinine of about 1.9. Which of the following treatments would be associated with a decreased risk for AKI? And this is something that we talk about later in the discussion of why it's important to avoid patients getting acute kidney injury. So the options are intravenous crystalloids, started before he gets to the hospital, mannitol, dopamine, furosemide, and N-acetylcysteine. So the answer to this question is actually A. You want to start volume replacement. This is one of the best things that we can do to prevent crush injuries from causing kidney damage. You also want to give them fluids just to avoid any sort of alkalization in the kidneys, and that can also then decrease the cycling of myoglobin and the generation of reactive oxygen species. So last question, 57-year-old gentleman was in a motor vehicle accident. He had multiple fractures and blunt chest and abdominal trauma. His blood pressure is really low, 95/60. His left hemothorax is treated with the chest tube. He gets washouts and little blood in the abdomen. Non-contrast CT shows nothing. He gets a ton of volume, about 5 liters, and his blood pressure comes up to 135/85. However, within 24 hours, he starts to have significant abdominal distension. His amylase and lipase levels are elevated, and his urine output starts to go down. And his serum creatinine is up to 2.3. When we check the central venous pressure, it's 18, but his urine sodium is 12, and his urine sediment shows some CAS. And the renal ultrasound shows a little bit of, hematoma, but no swelling around the kidneys or anything with the kidneys, but he does have fluid in his abdomen. And his intravesicular pressure is 27. So which of the following is the most appropriate management of this gentleman's renal failure? Abdominal decompression, giving him ureteral stents, continue with fluid resuscitations, just watch him or start him on renal replacement therapy. And in this gentleman, you want to decompress his abdomen. So he's showing signs and symptoms consistent with abdominal compartment syndrome. And this is usually noted in patients who, increased risk with trauma patients that have intra-abdominal bleeding, have had recent abdominal surgeries, massive fluid resuscitation, patients who have peritonitis, pancreatitis, ileus. You diagnose it by getting a intra-abdominal or intravesicular pressure, which is usually above 20. And you can also see that they have acute kidney injury like this guy did with oliguria, and a pre-renal state where their urine sediment really doesn't show anything. And so the treatment was abdominal decompression. So why do I care so much about kidney disease? I talked about it extensively just now. Well, because it is almost twice as deadly as having a myocardial infarction. You see it in about 7 to 18% of hospitalized patients. Up to 50% of critically ill patients have some degree of acute kidney injury. It's 9 times higher risk of development of chronic kidney disease, which incurs a cost later, and 2 times higher risk of premature death. And the estimated annual cost to the US healthcare system for acquired acute kidney injury is about $10 billion. So what is acute kidney injury? This is a clinical syndrome denoted by the sudden decline in eGFR, or glomerular filtration rate. It's the reduced excretion of nitrogenous waste and other uremic toxins, dysregulation of the extracellular volume, and abnormalities of the electrolytes. So these are some things that you'll see. You may not see all of them. You may see 1 or 2 of them, but that is acute kidney injury. So who's at risk? Who do we worry about in this for this thing? The elderly, of course. Females are at higher risk. Patients with a history of chronic kidney disease, patients with diabetes, patients who are volume depleted or who have low protein states to begin with, people with heart failure or low ejection fractions, people undergoing cardiac surgery on or off the pump, chronic liver disease, malignancies, peripheral vascular disease, and dementia patients. So where and when do we start seeing kidney injury. And when does it start showing itself in blood work? Well, we actually are not able to see the kidney disease happen prior to the lab changes. So it's a delayed identifier. We're seeing kidney disease happen when the GFR drops, but that's because the damage has already happened. And we're trying to find out ways to figure out how to diagnose it when there's an increased risk, rather than getting to the point where we have a drop in GFR, because those are the markers that we have available. So our goal is to predict and minimize the onset and long-term consequences of acute kidney injury. But the models that we have right now to diagnose acute kidney injury occurs after damage is already done. So we'll talk about how we currently diagnose acute kidney injury and what's in the pipelines for the future. So there's two criteria that have been introduced. So the first one was RIFLE. That was done back in about 2004, which is the risk, injury, failure, loss of function, and end-stage renal disease. And then AKIN came out after that, which was created by the Acute Kidney Injury Network, which was in about 2005. They got together to create this new classification, and they published it in about 2007. So this is the RIFLE criteria based on risk, injury, and failure. It also takes into input urine output. So this was proposed by the Acute Dialysis Quality Initiative, so back in 2004. It provided 3 grades of severity for acute kidney injury based on changes in serum creatinine, estimated GFR, and urine output. The strengths of this classification were in that it was validated in terms of determining the incidence of acute kidney injury and a prognostic stratification and accuracy in terms of mortality. And it also gives us the ability to monitor the progression of acute kidney injury severity during hospitalization, but it is limited by the need for a baseline serum creatinine. So if you have a patient who's never shown up in the hospital or seen a doctor and they have an elevated creatinine, you're unable to tell if this is acute kidney injury versus chronic kidney disease or acute on chronic kidney disease. They did add to their criteria that you could calculate their baseline creatinine based on the MDRD formula. However, that formula is not valid for acute states. And the other part of this criteria required urine output, but it's very hard in an acute state to measure a urine output if you don't have a Foley catheter in, or if a patient's on diuretics. That can change the criteria. And then, of course, the other 2 stages of RIFLE are loss and end-stage renal disease, and that is very subjective, dependent on the physician and the hospital that is seeing the patient, and on at what levels do they initiate dialysis and things of that sort. So after RIFLE made its debut, the acute kidney injury came out and modified what RIFLE was, and they published their criteria in 2007. So one of the big things RIFLE had in there is that AKIN does not, is removing the terminology acute renal failure. They changed it to acute kidney injury. So that is what we see now. So about a decade ago, we were calling it acute renal failure. Now we're calling it acute kidney injury. This also put in a caveat that you can only use this criteria once volume status has been optimized and urinary obstruction has been ruled out, because those 2 things can affect your creatinine. And then the other thing was, this doesn't rely on eGFR, it relies on serum creatinine changes. And you don't really need a baseline serum creatinine if you have 2 creatinine levels within 48 hours to make this diagnosis. But one of the limitations because of that is you won't know prior to those 48 hours if they were an acute kidney injury or not. And the stage 3 classifications, again, same thing with rifle, the commencement of renal replacement therapy varies. So any questions, anything so far?
Yeah, based upon the chat, heard a lot of people being complicated. This like not being able to understand, and that's completely fine. Even I'm an undergrad, and a lot of you guys are in high school. If you guys don't get all this technical information, that's completely fine. But at the end of the day, you should find this information intriguing. And when we do complete all of this, we're gonna be able to talk like this. So that'll be cool. But other than that, there was a question about. There's a lot of questions about summaries, guys. Summaries are quick, like I said before, 3 to 4 sentences. Email them to clubmedshoe@gmail.com. No specific format. Anything that works for you guys is fine. You can only write your summaries from the 2021 session. All other summary sessions are closed. There was a question, why are females more at risk for
that partly has to do with body mass and muscle mass. Men tend to carry more than women, so a slight discrepancy in that will cause women to be a little bit more at risk for developing chronic kidney disease than men.
Okay. Brenda asked, do you currently use Aiken?
No, so we actually now have moved to KDIGO's classification. So KDIGO is the Kidney Dialysis Initiative of, global organization. And so they are Kidney Disease Improving Global Outcome. They took Akin and they took Rifle, and they combined the two to make a more concrete way to diagnose acute kidney injury. And so that is what we use now, is the KDIGO criterias. And this is the classification. So when someone's creatinine goes up 1.5 times their baseline, or they have an increase in 0.3 and a drop in urine output, so on and so forth. So this is the criteria that we now use.
Okay. The question was that it's from Keely. If you constantly get kidney stones, can that be a sign of getting a kidney disease?
Yes. So chronic kidney stones that's obstructive uropathy that we're talking about here. So, repetitive acute kidney injuries will progress you to develop chronic kidney disease. So every time you block your ureter or your urethra with a kidney stone, it does put you at a higher risk of developing chronic kidney disease over time.
Okay. Another question from Kaylin. She says, I've heard nephrology includes a lot of organic chemistry compared to other specialties. Is this true, and how does it affect into your daily work?
So I still have the occasional nightmares of organic chemistry, but I will tell you this much. I have never drawn a carbon molecule or had to refer back to my organic chemistry days. But that basis of acid-base reactions, calcium precipitation in the kidneys, a lot of that does come back to you in nephrology. So the one field that is more mathematical based or science based when it comes to reactions would be nephrology.
Okay. Question from Maida. She goes, she asks, are there any ethnic variations or risk factors that contribute to kidney disease? Are there any movements besides education to address these inquiries?
So there is actually, just recently, there was an article published in some of the renal journals about the African American classification of EGFR. There's been many a papers done between, the calculations and the formulas, the MDRD, the CKD epi, oh gosh, I'm blanking on all the formulas that there are, but there was a specific numerical value that we gave to the African American population versus the non-African American population. However, as time has gone on, we have realized that that was a more subjective classification. It wasn't based on any genetic composition. So if you identified yourself as African American, you fell into that African American formula, despite your genetic background makeup can be, 50% Caucasian and 50% African American. Which formula do you use? So they have now started to give a single numerical value for estimated EGFR without the African American modifier.
Gotcha. There's there's a lot of questions, but we'll keep moving on. Is there, if people have specific questions, is there a way they can reach out to you, and how could they do that?
Yeah. Well, TikTok is one. I do a lot of lives and things like that. So you can catch me on TikTok talking about stuff, but shoot me a DM on Instagram. I am a private account, but I do check my other messages. I don't really put a lot of medical information on Instagram, but I can be reached on that platform. So yeah, just find me online and I can definitely answer any questions that anyone may have. Let's get to some stuff that may be a little relevant to everyone that is here. So prevention. This is something I'm going to skip all the nitty gritty about diagnosis, but why do I care to prevent? How and why do I want to prevent acute kidney injury? Simple things, you want to avoid medications that cause kidney injury. Contrast, anti-inflammatories. This is a big one. This is something that you guys can talk to your parents about, your loved ones. Chronic use of over-the-counter medications. This will cause kidney damage, especially if you have high blood pressure, diabetes, other comorbid conditions. If you are popping ibuprofen left and right, please go get evaluated. Get your kidneys checked. Let somebody see your numbers. You're not going to have any symptoms of kidney disease. It's a very silent killer. It's not going to give you shortness of breath. It's not going to give you palpitations like cardiac issues will, or pulmonary issues. It's slow growing, indwelling. So you want to get that evaluated. Volume depletion, hypotension, again, dehydration, these kinds of things will also put a strain on your kidneys. You don't have to chug gallons of water every day. Drink to your thirst, but, don't dehydrate yourself. And look at the color of your urine. You want your urine to be a pale yellow. If it looks like, you dumped a highlighter in the toilet, drink some water. And then let's see. So this is, contrast-induced nephropathy. That's something you'll see in the hospital. So what we use, stage-based management of acute kidney injury. Things that you can do when you see somebody have, elevated kidney numbers. You want to kind of look at causes that are easily fixable. Stop any medications that hurt the kidneys, give them some volume if they're dehydrated, watch their blood pressure, watch their numbers, watch their urine output. If you have to give them contrast, see if there's any ways you can skirt around that, or if you have to give it, pre-treat them, make sure you make the kidneys as happy as possible. And as you go on with the stages, you have to look for other things. You talk about renal replacement therapy. You want to avoid catheters in the neck in case that they may need dialysis in the future. You want to preserve the veins that are up in the upper chest area. And then, of course, prognosis. So this is why we talk about acute kidney injury a lot. And how bad your kidney injury is with an acute condition will correlate to your outcome, and correlate to your mortality later in life. So high level, high degree, stage 3 acute kidney injury in the hospital will leave you with stage 1, stage 2 chronic kidney disease if you didn't have any going in. So, it definitely does affect the baseline kidney function. Obviously, if you're urinating and you have kidney injury, that is a favorable outcome compared to if you are anuric or not making urine. That has a worse outcome. And again, when compared to patients who have no kidney involvement, a third of those patients with transient acute kidney injury have an increased mortality. And that increases in those patients that have cardiac surgery. So I'll give you a case that I had in the hospital. I had a lady, 60-year-old diabetic, had a massive heart attack. Before she went into the hospital, she, kidneys functioned about 70%. Her eGFR was about 70. Massive heart attack, had pleural effusions, had a chest tube in place for a prolonged period of time, was on a ventilator for several days post surgery. A very sick lady. She ended up actually developing acute kidney injury, and actually her kidneys shut down to the point where we did have to start her on chronic renal replacement therapy. So this is that 24-hour slow volume removal dialysis for a few days, and then kind of let her kidneys wake back up slowly. And now, after all of this, about a year and a half later, she definitely has worsening chronic kidney injury to now her baseline creatinine is a little higher, and her, functioning percentage is about down to 40%. So she lost about 30% of functioning kidney just by being on dialysis for a few days after an open heart surgery.
More questions from the chat. Typically a session is about 1 hour. Going to let me find it. There's so many questions, like it just passes by.
Yeah.
So we have to. Okay, so Nicole asks, creatine kinase is an enzyme that leaks from damaged muscle. So how do you know that high levels of CK is specifically from kidney disease or a damaged kidney?
So creatinine kinase doesn't indicate kidney damage. Creatinine kinase, if elevated, will strain the kidneys. So you can see there's creatinine kinase MB, MM, just like troponins, there are different forms of troponin. So depending on what type of muscle is releasing the creatinine kinase, that will tell you where the injury is at. So you will see an elevated CK. So like the gentleman that had rhabdo, that had the crush injury, his creatinine kinase was elevated. So the CPK or the CK was elevated to 2300. That then put a strain on his kidneys. But you can also have a CK elevated when someone has a myocardial infarction, and that is creatinine kinase coming from cardiac muscle.
Gotcha. Interesting question from Kiera. What's the worst over-the-counter medication for your kidneys?
Ibuprofen.
Ibuprofen?
It is the bane of my existence.
And that's the most common medication that you find in any household.
Absolutely. You have any aches, pains, fevers, headache, everyone pops ibuprofen.
So watch what you're eating, watch what you might, ibuprofen might help you with the pains, but there might be a little bit of a side effect along with that.
A link to recent events, they were saying when people started getting COVID and having fevers from COVID, one of the first things that had come out was, don't take ibuprofen, take Tylenol.
This is acetaminophen.
Right. And Tylenol flew off the shelf this, March of last year. You couldn't find it in the stores. And it was with the pathway that ibuprofen acts in the body that they were saying that would worsen COVID, which is the cytokine storm that you get from COVID. But we now know that it didn't make a difference if you took ibuprofen or Tylenol when you got COVID.
Right. Could you show a picture, like what a damaged kidney looks like from taking like ibuprofen?
I would have to Google that because I don't have one on my computer. So let's see. I'll stop this real quick. Let's see.
Guys, while she's looking that up, a little bit about the summaries. A lot of questions. I've answered it about 3 times, but all sessions from 2021 are eligible. And regarding questions about high school, you guys asked, and then we said that we can do a live session for you guys regarding talking about high school advice. We'll do that. But a little bit from my experience, I would say the type of things you could do in high school is definitely get involved with pre-medical, pre-med club or doing service. One thing medical schools look for is a commitment to service, community service, volunteering through your hospital. And not only for that purpose, that's something for you too. You can actually see, can you see yourself being a doctor by working, even if it says volunteering, but that's something that's important. Regarding classes, you guys asked, should I take AP classes? I would, from my experience, I would recommend taking AP classes. And the goal is to pass the AP exam, but if you don't pass the AP exam, that is completely fine. At the end of the day, you walk away with information that you're gonna, when you get into take Gen Chem in college, you already know the information. You don't have to relearn it again. So that's something that helps you. So I would say but I wouldn't, at the same time, I wouldn't overwhelm your schedule by taking 5 AP classes or 6 AP classes your senior year. That's not needed to. You'll have time in your undergrad to take those classes, but it's still to get ahead and make your undergrad a little bit easier. Just advice from me. And this session will be posted. There's a question. This session will be posted afterwards, so you guys can visit. Do you have a picture? Did you get a chance to?
You guys are making me look up stuff in my textbooks now. I'm going back to the books. The best I could find is biopsy. I don't know if y'all can see that, but we really see it on histological slides of, the effects of ibuprofen. The kidney itself, the contour, the texture of it looks about the same. And that's really no exciting pictures there.
Okay. Another question, what about other supplements like fish oils, multivitamins, those kind of things?
Those are okay. Now, what you want to stay away from are the herbal supplements, the stuff that you get from overseas that are not really monitored or looked at by anyone. Fish oil is safe. Multivitamins are safe. The herbs that, some people take, like St. John's wort, can cause some issues. We've seen kidney injury from that. There's saw palmetto that's caused injury. So you just have to be careful with what supplements you're taking and read the labels of what's on there. And of course, if you have any questions, run these supplements by your physicians. Make sure that there's no interactions with the medications that you're taking. Certain medications, can affect how Coumadin, a blood thinner, works in your body, how other medications, other antibiotics interact. So you want to just make sure that whatever you're taking is labeled and, make sure it's just not in another language. It's written in English.
Gotcha. Another question. Could you just touch like what your typical, we talked about a lot of medical information. What does your typical workday look like?
So nephrology is actually a really good specialty if you want work-life balance. You know, a lot of specialties are procedure heavy. You know, cardiology has their caths and things like that, which will rush you to the hospital. Nephrology is one of those where, you know, if you're in a group, typical day, you start clinic 8 to 5. If you have, you know, on-call duties, you go to the hospital afterwards. If you round in a dialysis unit, you find 1 day a week to go and see your dialysis patients. So currently for me right now, I'm private practice. I'm by myself. My clinic's open Monday to Saturday. Monday through Friday, I'm there 8 to 5. Saturdays, I'm there from 9 to 1. Wednesdays, my clinic is closed, but I do spend Wednesdays rounding on all my dialysis patients. So first and second shift, I see all the dialysis patients, take care of all their needs. And then, of course, in between there in the mornings or in the evenings, if I have patients in the hospital, then I'll go around in the hospital. And then Sunday, it's free to do whatever, unless there's someone in the hospital.
Okay. Going back to the question about side effects, somebody asked from Haley, do antidepressants have any effects on your kidneys? Do you know about that?
Antidepressants may need to be dosed for your renal function, but they shouldn't cause any injury to your kidneys.
Another question from the chat was regarding your private practice. You said that you have your own clinic. Could you talk a little bit about that? Like, how difficult was it to open your own clinic?
So I was lucky. I got my dad's clinic.
Oh.
I didn't have to do much work, but it is, you know, we're moving into an age of medicine where working independently is hard. There's a lot of red tape. There's a lot of upfront costs that are involved in running your own clinic. And the insurance companies definitely don't make it easy on you. And the hospital systems are trying to get people to come into groups, more so multi-specialty groups. So you'll see, you know, a primary care with a cardiologist, with an endocrinologist, with a podiatrist, all in the same office. So that way one patient can see all their providers in one spot rather than traveling to different locations to see different people. But being in private practice, being by myself, having the autonomy, having the ability to basically do what I want does help out.
Gotcha. I found a picture for acute renal failure. Could you talk a little bit about what we're seeing in this picture on the left-hand side?
They're really just shriveled up kidneys, right? So a healthy kidney you see has good contour, doesn't have any sort of wrinkles on it, but a damaged kidney from necrosis, from deposition of something, basically gives you a diseased kidney. You can see that there's some decrease in their cortical mass. These kidneys are probably a little smaller than the healthy kidney. A healthy kidney is about 10 to 12 centimeters. But as there's acute injuries and lack of blood flow or, you know, insults of any kind to the kidney, they do tend to kind of shrink up. Diabetics, patients who have amyloidosis, patients who have deposition disease, cysts will have enlarged kidneys. So polycystic kidney disease, their kidneys are almost the size of a football, and does compress on their intestines, gives them discomfort, gives them pain, and can cause a lot of discomfort. So usually we don't take out patients' native kidneys, especially after they get transplants. We keep them in. The only instance that we will probably consider doing a nephrectomy of a native kidney is if their kidneys get too large for the size of their abdomen and it needs to come out. And then, of course, renal cell cancer, you know, carcinomas of the kidney that we would take out a kidney.
Gotcha. I'll stop sharing that. Going back to the questions. So we said that you said that like ibuprofen can cause some damage to kidneys. Anything to replace ibuprofen, like what would you recommend?
So it's not that you can't take ibuprofen, right? So you can, minor aches and pains, if you're taking it once a week, once every few weeks, ibuprofen is a safe medication. Or any NSAID, right? Motrin, Aleve, naproxen, naproxen, any of those are decent anti-inflammatories. The thing is, you can't overdo it with a singular medication. So if you're taking 8-10 tablets of some type of NSAID a day for multiple weeks, yes, you will develop some sort of renal injury. But if you're judicious about the way you take it, if you mix it up with Tylenol, the risk of kidney injury goes down. It's not nil, but it's not significant to where it will cause you injury.
There's a question related to that from Emma regarding injury. Is there a specific part of the kidney, the nephron, the glomerulus, or the DCT that is more susceptible to injuries?
So it depends on the type of injury, right? So you can have glomerular injury if you have some sort of glomerular nephritis, high VAN HIV associated nephritis, things that affect the glomerulus itself. You can have tubular injury, depending on depositions, cast nephropathy, things of that sort. The tubules can get damaged. You can have cortical injury if like a biopsy goes bad. You can have vascular injuries if there's a vasculitis. So again, multiple parts of the kidney all work together in unison, but if any one part goes down, then you can have, some injuries. And I'll show you, I actually had a slide on that. Let's see. Here it is. So I'll share this screen with you guys. So this, again, depending on which type of intrinsic kidney injury you have can have glomerular, interstitial, tubular, or vasculitis. So the three different types of kidney injuries, before things get to the kidney. So blood pressure, decreased cardiac output, heart failure, again, NSAIDs, blood pressure medications, immunosuppressant medications, all of these things happen before the kidney, which can damage and cause your numbers to go up. Intrinsic is what's happening inside the organ itself, meaning the glomerulus, the interstitium, the tubules, the vasculature. And then of course, post-kidney, things that happen bladder below. So, or ureters below. So kidney stones, enlarged prostates, prostate cancer, scarring of, your retroperitoneum, which is what encases the kidneys, or bladder or pelvic malignancy. So in women, uterine cancers or ovarian cancers, things that can impinge on the ureters and cause your kidney numbers to go up.
Gotcha. Guys, there's a lot of questions, but we're already 5 minutes over time. I'm sorry if I didn't get to your guys' questions. I tried my best to and ask as many questions as I could. But I see a lot of people are, okay, there's one question I'll ask. This is the last question I'll ask, which is, I've experienced rhabdo after working out with the 6,000 CCAN. I'm a healthy 22-year-old. How do you explain this in healthy, active individuals? Is it due to dehydration? Oh.
Not drinking enough water.
Yeah.
That is rhabdo. And also, if you're lifting heavy weights, you're putting strain on your muscles. You are stressing them, stretching them out. So you got to hydrate, hydrate, hydrate. Also, some of the pre-workout stuff that people drink have caffeine in them that dehydrates you. So, again, you have to be careful when you work out. Don't over stress, over push your body.
Okay. Sorry, guys. I didn't. There was a question that people ask a lot of times, so I got to it. Okay. But with that being said, I have a couple more things before we close out. So let's screen share. Okay, so it's been a really, really good call talking to you. So I want to thank you. First of all, I want to thank you for taking your time. I know you're a busy person, so thank you for coming and speaking with us. A lot of the audience, if I'm looking at everybody's appreciative towards you answering all the questions, giving all the information about kidneys and stuff like that. So thank you so much. With that being said, we will have more calls. So if you found this interesting, take more steps towards this. If kidneys interested you, take more steps towards that. And doctor, what would you recommend if somebody who's interested in studying about kidneys?
Kidneys.
Yeah.
Oh, I never thought about that.
Probably like shadow a physician.
Yeah, go to a nephrologist. You'd be surprised at the wealth of information a nephrologist can give you. We touch base on all the specialties because everything kind of ties in with the kidneys, but find your local nephrologist, and many of them would love to talk to you about medicine. We love to share our information.
Gotcha. With that being said, we run this program at no cost to anybody. So these calls will remain as free as we can. We know that due to COVID, it's difficult for you guys to be able to shadow, but if you can shadow, do that because that's important. It gives you an opportunity to see what it's like to become a doctor. It gives you an opportunity to see if that's something that you want to do. But we'll continue to have these sessions. And if you want to stay up to date with what we're doing, go to the link in our email, in our bio, and click on to sign up for the email notifications. And every week we will send you out information of what we're going to have, and that'll be ahead of time. So that way you know what time it is, what's going to be about. And all calls in 2021 will be eligible for getting a certificate. Be patient with that too. We're doing this by hand. It's a select few of us who try to get this process. So we try to get it done as quickly as possible, but it can get backed up. So be patient with that. And if you can, please donate. Anything will go a long way. You can Venmo, Cash App, anything that you can send. Any amount is fine. It'll help us go a long way. We have to pay for things like email server that we have for Zoom and stuff like that. We have costs associated with that. So anything that you can donate is really, really appreciative from us. And before I go, another thing I want to say is that easiest way to come and get a notification is also by just subscribing to our YouTube channel. So if you subscribe and when we go live next time, you'll get a notification we're going live. So that's easy way to also keep up with what we're doing. And thank you for everybody who came today. We had a big turnout. We had 700 people who came today. So thank you to each one of you guys taking the time to come and see what we did. And we hope that you return to the next week call. And that is it from today. Thank you, everybody.
That was fun.